What's up, Ninja Nerds? In this video, we're going to be talking about a rapid review of inflammatory bowel disease. That includes ulcerative colitis and Crohn's disease. If you guys want some notes to follow along, some awesome illustrations, down in the description box below, we'll have a link to our website. Go check that out. Also, if you benefit from this video, you like it, it makes sense, please support us by hitting that like button, commenting down in the comment section, and most importantly, subscribing. Also, before we get started, if you guys want a more detailed look at ulcerative colitis, a more detailed look at Crohn's disease, we have individual videos on our gastrointestinal pathology playlist, so go check that out. All right, let's get started on a rapid review of IBD. All right, so let's talk about the causes and pathophysiology of inflammatory bowel disease. Again, there's Crohn's and ulcerative colitis. Crohn's disease, when we talk about the causes, again, both of these have some type of autoimmune relationship, meaning that there's a genetic, an immune, and environmental component involved. What I want you guys to remember is that specifically with the immune system involvement in Crohn's, it seems to be modulated by these Th17 cells, releasing lots of that interleukin 17. In addition, there seems to be a lot of Th1 cells, releasing lots of tumor necrotic factor alpha, interleukin 1, interleukin 6. And this is causing a lot of that inflammatory process within the bowels. In addition, one of the mutations that we see within Crohn's disease is specifically that NOD2 mutation. Now, in ulcerative colitis, there's not so much of those Th1 cell involvement, it's more Th2 cell involvement. So they release cytokines like interleukin 5, interleukin 13, which causes a disruption in the epithelial barrier of the GI tract. In addition, there seems to be a lot of activation of cytotoxic T cells, and that causes direct cytotoxic destruction of the epithelial cells and parts of the GI tract wall. And lastly, there seems to be lots of antibodies, particularly P-ANCAs, pericytoplasmic anti-neutrophilic cytoplasmic antibodies, that are made by plasma cells that also can cause this GI tract involvement and inflammation. Now, the good question that you guys should be asking here is, when we talk about Crohn's disease, this inflammation, where can it involve? Is there a specific area of the GI tract? Actually, it can occur anywhere along the GI tract, but the most common location that you need to remember is going to be the last part of the small intestine called the ileum and the colon, but more specifically, the right side of the colon, so the ascending colon. That's very, very important to remember. And usually it spares the rectum. Whereas in ulcerative colitis, it usually always involves the rectum and then spreads contiguously up through the sigmoid, up to the distal colon, particularly the descending colon, transverse colon, and it can even involve the ascending colon. So remember, it starts in the rectum, works its way to the sigmoid, to the descending, to the transverse, and the ascending colon, has the ability to involve the entire colon, called pancolitis. All right, so when we talk about Crohn's disease and we look at the inflammation that's involved within the GI tract, right, for Crohn's, specifically, if we look at the microscopic level, it's really important to remember this, guys, very high yield, that with Crohn's, it's transmural. What does that mean? That means that the ulceration or inflammation, the lesions that you get, involves the mucosa, it involves the submucosa, it involves the muscularis externa, and it involves the serosa or adventitia of that part of the GI tract. So it's called transmural inflammation. Whereas with ulcerative colitis, it only involves the mucosa and submucosa. So you get ulcerations or lesions that involve only the mucosa and submucosa. That's that part of causes and pathophys. Let's now see how this inflammation affects the GI tract, particularly comparing Crohn's and ulcerative colitis, and what are some of the similarities and extraintestinal manifestations between Crohn's and ulcerative colitis. All right, so let's continue our talk on the causes and pathophys of Crohn's versus ulcerative colitis. Now, with Crohn's, again, we know that there's a lot of that Th1 and Th17 cell involvement, lots of inflammation anywhere along the GI tract. But again, where's the most common location that I told you? The ileum and the right side of the colon. So ileum and the right side of the colon, obviously the cecum and just the beginning parts of the ascending colon, where's that pain going to be most likely located? If you have inflammation and pain that is referring from that area, it should be the right lower quadrant. And that makes sense based upon where the inflammation is most commonly going to occur. So right lower quadrant pain is a big, big thing for Crohn's. Whereas, if you think about ulcerative colitis, where does it usually always have to start? At the rectum. And then from there, it can involve the sigmoid colon, and then it can involve the descending colon, which is on that left side. If it does, where is the most common location of the rectum, the sigmoid colon area? That left lower quadrant. So they're more likely to have left lower quadrant pain for ulcerative colitis in comparison to Crohn's, which is right lower quadrant pain. Also, because the rectum is usually almost always involved in ulcerative colitis, they usually have lots of pain and also this feeling like they haven't completely emptied their bowels, and this is called tenesmus. So that's a big, big thing to remember for ulcerative colitis. Next, When we think about Crohn's disease, it involves the small bowels and it involves the large bowel. The small bowel is important for a lot of absorption of nutrients, right? So if you have decreased absorption of nutrients because of, in Crohn's it involves the small bowel, what would you get? Malnourishment. You won't absorb things like glucose and fats and proteins. And so that could lead to weight loss. It could lead to failure to thrive. That's important to remember. Now, because it involves the large intestine, it could lose water. Now, small intestine also absorbs water, but the large intestine is the big one. So if you're not absorbing water across the large intestine or the small intestine, what happens? You don't absorb it across, instead it stays in the poo-poo, you get watery diarrhea. Here's the big thing though to differentiate. In small bowel involvement with Crohn's disease, remember we have bile salts. That's a very important component of bile. If you don't absorb bile salts across the ileum, which is a part of the small intestine in Crohn's disease, bile salts aren't going to be incorporated into the bile. And therefore, what happens? Cholesterol molecules don't have bile salts to combine with. And so you get these things called gallstones. Lastly, in patients with Crohn's disease, if you don't absorb lots of fats, the fats stay within the bowel and bind to calcium. You don't bind calcium, instead you absorb lots of what's called oxalate. And that oxalate starts forming crystals that can form kidney stones. You see gallstones and kidney stones in Crohn's. You do not see that in ulcerative colitis because it doesn't involve the small bowel, right? Whereas in ulcerative colitis, it's primarily having lesions that are involving the large intestine. The large intestine, the most important thing is water reabsorption. So you lose water here in the actual poop. So you get watery diarrhea. But guess what? Because there's more bloody kind of involvement, more ulcerations within that large intestine area, near the rectum, near the sigmoid colon, you get blood that becomes more obvious than you would if you had someone with a right-sided colon type of bleed. The bleeding will be more obvious within the stool on a left-sided bleed of the part of the colon. So they get bloody diarrhea, even with mucus-containing molecules as well. So that's the big difference. Watery diarrhea, Crohn's, bloody diarrhea within ulcerative colitis. This malabsorption with Crohn's and gallstones and kidney stones only in Crohn's. Now, if we continue down and we talk about what are the other GI tract involvement here, this is big stuff. Crohn's disease, you get fistulas. What is that? That's connections. Remember, there's kind of ulcerative lesions that work its way through the GI tract wall, and it's basically a tube connection between the GI tract, where there's inflammation, to other organs. What if a fistula connects from the GI tract to the actual bladder? It's called an enterovesicular fistula. What if it connects to the skin? Enterocutaneous fistula. What if it connects to another part of the actual colon? They call it enteroenteric fistulas. So you can get these nasty fistulas, which can be problematic. Also, if you get these ulcerative lesions that work its way through the GI tract wall the entire way, bacteria can just encroach into that area and cause abscesses. So you can see perianal abscesses in patients with Crohn's disease. You do not see that in patients with ulcerative colitis. You see fistulas with Crohn's. You do not see that with ulcerative colitis. Last but not least, you're more likely to see strictures, particularly involving parts of the small bowel, the right side of the colon, in patients with Crohn's disease, more so than you would in ulcerative colitis. And what's the problem with strictures? They increase the risk of bowel obstructions. And last but not least, because Crohn's disease involves both the small bowel and the large bowel, not only do you have a risk of colorectal cancer, but you have the risk of small bowel cancer because of that constant replication cycle. So that's comparing these. Other GI tract complications for ulcerative colitis is if you get a significant amount of inflammation of the GI tract wall to the point where you're having signs of fever, white count, and 10 plus stools a day of bloody diarrhea, that's called fulminant colitis. The scary complication that you see with UC though is that sometimes that inflammation causes the actual large colon to dilate to the point of greater than or equal to 6 centimeters on radiological exam. Signs of leukocytosis, signs of fever, signs of hypotension, tachycardia. This is a high risk of perforation. That's called toxic megacolon. You see that in UC, you do not see that in Crohn's. The other thing that you can see in Crohn's, but you see it way more often in ulcerative colitis, is primary sclerosing cholangitis, inflammation of the biliary tract wall. And because it's way more common in patients with UC, if you have lots of inflammation of the biliary tract wall, it increases the cancer risk of that biliary tract. And that is called a cholangiocarcinoma. So that's a big thing to remember. PSC, more common in UC than you would have in Crohn's. Last but not least, because the actual UC involves primarily the large bowel and does not involve the small bowel, it only increases the risk of cancer, particularly confined to the colon. So colorectal cancer only in UC, not small bowel in comparison to Crohn's. And colorectal cancer has a higher risk in patients with UC in comparison to Crohn's disease. Now, what are some of the extraintestinal manifestations that is the same between UC and Crohn's disease? All right, so we've talked about a lot of the differences between ulcerative colitis and Crohn's disease, right? As a part of this inflammatory bowel disease kind of spectrum. Now, is there any similarities, especially extraintestinal manifestations? You know, whenever there's a lot of inflammation going on, particularly from the TNF alpha, interleukins, all of those things, it can get systemically and involve other different organs. What are some of these organs? Big thing to think about, eyes. So they may have signs of uveitis. There also may be evidence of what else? Particularly episcleritis. Now, not only do they have ocular involvement, particularly uveitis and episcleritis, they may have dermatological or skin involvement. They can get these nasty like red lesions that can appear on the extremities called erythema nodosum. They can also develop other types of nasty kind of necrotic looking skin lesions that can appear on the extensor surfaces called pyoderma gangrenosum. Now, we know about the ocular involvement, the skin involvement that can be the same in both of them. What about particular joint involvement? Now, we see very specifically both of these diseases seem to be associated with HLA-B27 haplotypes, seronegative spondyloarthropathies. What the heck does that mean? That means that these can show up similar to conditions like ankylosing spondylitis, Reiter's syndrome, or also known as reactive arthritis, psoriatic arthritis. This is a category called IBD arthritis, or enterohepatic arthritis. And so they can present with inflammation of the vertebral column called spondylitis, back pain. They can present with sacroiliitis, inflammation of the sacroiliac joint. They may have hip pain. And they also can have peripheral joint involvement, so just arthritis of maybe the actual extremities, particularly the digits as well. So that's the extraintestinal manifestations. Now, let's talk about the diagnosis and comparison and differences between UC and Crohn's. All right, so let's talk about how we diagnose inflammatory bowel disease, specifically trying to differentiate along the way between UC and Crohn's disease, right? So we can start off by doing the antibody testing. They're not super sensitive, but they're somewhat specific. So one of the things that we can do is remember, we talked about in Crohn's, you can have what's called these anti-Saccharomyces cerevisiae antibodies or ASC antibodies. They'll be positive. That's not a super great test. What I tell you guys to think about is not just will they have ASCA antibodies that are positive, but they will not have positive P-ANCA antibodies. That's a big thing to think about. Ulcerative colitis, they do have positive P-ANCA antibodies. Pericytoplasmic anti-neutrophilic cytoplasmic antibodies. So that's a big thing that's right off the get-go. Crohn's, ASCA positive, P-ANCA negative. UC, only P-ANCA positive. All right? Next thing. We can look at some imaging. We can do a bunch of different studies. You can do colonoscopy, you can do an abdominal x-ray, you can even do different barium studies, whether it be kind of a swallow or an enema. There's a bunch of different things. There's a bunch of buzzword terms that we need to know though. All right, so the first thing for Crohn's disease, if we did a colonoscopy and we took and looked at the actual colon, what would it look like? Well, the big thing is that you have these areas of destructive lesions, then normal, then destructive, and then normal. And on top of that, you have maybe in between these areas of destructive lesions, normal tissue, but the tissue there's a thickening of the bowel wall. So there's two things that you can see. One of them is on the colonoscopy, if you look, you see destructive tissue, normal tissue. Those are called skip lesions. In addition, you may see areas of destructive tissue, inflamed tissue, destructive tissue. And you may see that also on the colonoscopy, and this is called the cobblestoning sign. Now, the next thing that we could also see is if you got an actual CT study or an MR study, particularly MRE or CTE, there may show a lot of this excessive mesenteric fat near this area of bowel wall inflammation. And usually this is called the creeping fat sign. And last but not least, if we did what's called a small bowel follow-through, we had patients taking ingest contrast, and we followed the contrast throughout their bowels. We would see areas of strictures, or we would see areas of this narrowing through the bowel wall, which is called the string sign. These are very high yield things that I need you guys to know for Crohn's. Now for ulcerative colitis, it's actually a little bit easier. We can do a colonoscopy, and when we do a colonoscopy, we'll see lesions that usually involve the rectum and continue its way ascending through the sigmoid, through the descending, through the transverse, through the ascending colon. So these are continuous ulcerative lesions with friable or easily bleeding types of mucosa. That is the big thing. So you'll see continuous lesions. Now, that would be on the colonoscopy. If you did a abdominal x-ray, or you did a little bit more of a different, an abdominal x-ray and shot barium up as an enema, it would show a loss of the haustra and more of a dilation of the actual GI tract wall, or the lumen. And we call this loss of haustration with some slight dilation what's called the lead pipe sign. And you can see this in an abdominal x-ray or a barium enema study. Okay, that's our kind of imaging differentiation. We can now differentiate them also microscopically. So if we took and did a colonoscopy and we biopsied the area, when we biopsy it, we obviously know that Crohn's has transmural inflammation. Ulcerative colitis has mucosal, submucosal inflammation. But the other thing is Crohn's has these things called non-caseating granulomas, macrophages, lymphocytes, fibroblasts, and fibrous tissue. And in the center is this area of giant cells with non-necrotic tissue called non-caseating granulomas. You see that in Crohn's, you do not see that in ulcerative colitis. In ulcerative colitis, you see destruction of these things called the epithelial crypts. You have these things called villi, and then a little divot called the crypts. These crypts actually get destroyed and have tons of white blood cells like neutrophils that had come into the area with all of that cellular debris and form kind of an area that looks like an abscess, and we call these crypt abscesses. So that's a big thing to also remember for ulcerative colitis. That covers the diagnosis. Let's finish off on the treatment between these two. All right, so let's talk about the treatment of inflammatory bowel disease, maybe covering a little differences between ulcerative colitis and Crohn's disease along the way. So first things, for mild disease, regardless of it being Crohn's or ulcerative colitis, you start off with what's called sulfasalazine or mesalamine. It's basically that 5-ASA. And remember, when we talk about these are for more of the mild cases, but what I want you to remember is that sulfasalazine is not as effective for Crohn's, but it seems to be a little bit more effective for ulcerative colitis because you can actually give it as an enema or a suppository in it for it to be able to really work locally in the area of the rectum and the sigmoid colon. So for ulcerative colitis, sulfasalazine is more effective than it is in Crohn's disease, okay? Next thing. For a flare-up, for a very moderate to severe disease, when they have this intense flare-up of their ulcerative colitis or Crohn's, corticosteroids seem to be the best for that flare-up and helping to induce remission. And so these can start off with budesonide. You can then take it up in the next notch if you have to do oral with prednisone or IV methylprednisolone. Now, after you've induced a remission type of state, you want to maintain that remission within UC or Crohn's. What are the drugs that are good for that? Well, that's where azathioprine or 6-mercaptopurine or methotrexate seems to be good for Crohn's and UC, but cyclosporin, what's called calcineurin inhibitors, tacrolimus and cyclosporin, seem to be a little bit more effective than azathioprine or 6-mercaptopurine or methotrexate in UC. So don't forget cyclosporin, maybe a little bit more effective for maintaining the remission in ulcerative colitis. Now, last but not least, we have our biologic agents that we can use for both Crohn's and ulcerative colitis. Now, first things first, the heavy hitter for Crohn's is your TNF-alpha inhibitors. Okay, that's going to shut that down because Crohn's disease has lots of that Th1 cell activity, lots of interferon gamma, lots of tumor necrotic factor alpha. So infliximab is going to be the best case scenario for that. For UC, it's also good. We do have some TNF-alpha release, interleukin-1, interleukin-6 release. TNF-alpha is definitely being released by a lot of macrophages. So TNF-alpha inhibitors are also good for UC, specifically, again, the infliximab. Now, where it is different, and we have the asterisk there to help you guys remember that, the interleukin-12, interleukin-23 inhibitor, also known as ustekinumab, is really only specific to Crohn's disease because interleukin-12 stimulates Th1 cell activity, interleukin-23 stimulates Th17 cell activity. You do not have that type of activity, particularly in ulcerative colitis. So we give drugs like interleukin-12-23, ustekinumab, only in Crohn's. And remember, it's because of Th1 cell activity and Th17 cell activity. Last but not least, for both of these, if the infliximab fails or the TNF-alpha group fails, you can have another option called vedolizumab for both of these. And vedolizumab is an alpha-4 beta-7 anti-integrin. All it does is it blocks white blood cells from coming into the area of the GI tract wall and into areas of inflammatory process within the GI tract, and helps to, again, induce and maintain remission. So your biologics are good for also inducing remission, but also maintaining remission as well. So this would be the medical therapy for UC and Crohn's. Now, when we talk about surgical, and this is where I really want you guys to remember, in someone who has Crohn's disease, they have inflammation of so many different parts of their GI tract wall, and it's in skip lesions. It's not continuous, it's discontinuous lesions. Doing a colectomy wouldn't be a curative type of procedure. It maybe would remove areas that are just super inflamed and damaged because of complications from Crohn's, but it's not going to be something that will cure the disease. In ulcerative colitis, it's continuous. So if they had inflammation of their rectum, their sigmoid, and parts of their descending colon, and it hadn't involved yet other parts of the colon, you could potentially remove that disease segment. And if you remove it, you prevent the progression from continuing throughout that process. Sometimes you may have to do a complete colectomy, but it just kind of depends upon the severity of the disease. So again, Crohn's colectomy is not curative. UC, it is curative, so don't forget that. And last but not least, for both of these diseases, they carry a high risk of colorectal cancer. Destruction, so they have this relapse, then they go into remission, relapse, remission. Multiple flare-ups creates a replicative cycle that increases the risk of mutations and therefore cancer. So after someone's been diagnosed with Crohn's disease or ulcerative colitis, 8 years after the diagnosis, they should get a colonoscopy. And then the frequency of colonoscopy kind of depends upon the severity, but generally we say every 1 to 3 years, depending upon the findings from that colonoscopy. Now, engineers, this covers our rapid review on IBD. I hope it made sense, and I hope that you guys enjoyed it. As always, until next time.